Joe,
Excellent.
you ready
I
to
think
kick
so.
things off?
Yeah, we're about 4:39. We're up to 100 participants already, and I'm still expecting more, but I think we can just we can probably get started. I'm going to do a little bit of housekeeping first, Barry, and then I'm going to turn it over to you before we then turn it over to Dr. Keith. And Keith, when we get started, let me know. I believe I can change the view to speaker view, and I made you a co-host, so you can share your screen if you want, and we'll take that route if that's good with you. And we were bragging on you before you came in here, so I'm really excited to have you back. Join us at Pulmonary Chat, and thank you, of course, to Carla and Barry at CAIRE and the whole organization. What a fantastic partner, and talk about a company that really cares about the people they serve. The name is quite appropriate. So first and foremost, I want to thank CAIRE for helping us along and helping Pulmonary Chat grow and providing such great resources for patients. So those of you who are new, and poor Ed has heard me say this, this is the third time I'm saying this now, but we do Pulmonary Chat the second, third, and fourth Tuesdays of the month every month. So 4:30 p.m. Eastern time, wherever your time zone may be, and Val Chang is probably the furthest off our time zone in Hawaii. But we do this all the time, and we're going to send you invitations. I promise we do not spam your email. But we will send an invitation, and if there's a meeting that tickles your fancy, see something that you want to learn about, we would love to have you come back. We have a number of different fantastic guests. So the way the format works is like Dr. Keith today. We're going to do a little bit of education time. We'll do some questions and answers, and obviously with a large group, it's hard to get to everyone's questions, but I'm sure we'll have a way where we can do that. But I am Joe Morrison, the CEO of Right2Breathe, co-founder. We have some of our board members with us. You've already heard John Linnell talk, and Bob Rollins, who are also board members. Allison Morrison, Mike McCormick, Michelle De Silva are board members on board. I think we have John Rakowski. I have not seen if John is signed in yet, but I know he's registered. Yes, I see him on here. Excellent. So we're blessed to have a bunch of our board members with us. I like to say I'm proud to be the dumbest guy in the room. I'm glad to be surrounded by great people helping great things happen, and it's the people around Right2Breathe that make it what it is. So just since there's a little bit of oh, and I'm going to ask you guys also, once we get started, to mute yourselves. And actually, I think there's a way I can hit mute all and do that. But that's the other bit of housekeeping here.
Started at 4:30.
Is to make sure, yes, there's somebody who's not muted. So, and if one of my co-hosts, if Carla or if you're familiar with the mute, let's see if I can do that. All right. So again, I was practicing on Zoom yesterday. I've been doing another platform for ages, but we won't talk about that. So with that said, really excited to have everybody join us, and I'm going to turn the program over to Barry from CAIRE, who will then introduce Dr. Keith, and then we'll get started.
Appreciate that, Joe. And, we're really pleased to partner with Right2Breathe on these sessions. So I think this is the third session we've done, and we've had more than 100 folks on the phone each time, which has just been fantastic. So it's great to see everybody turn out, and hopefully we believe we're sponsoring great content here that is hopefully very, very educational to you guys and useful to you all too. So today, we're very proud to bring you Dr. Keith Robinson. Dr. Robinson is a pulmonologist. He's currently the Senior Medical Director at Syneos Health. So Syneos is a global contract research organization that focuses on clinical development, medical affairs, and commercialization in the biopharmaceutical industry. So they work for biopharmaceutical clients to help bring new technologies to market. Dr. Robinson completed his fellowship in pulmonology at the University of California in San Diego in 2006. He's licensed and certified in pulmonary disease and critical care medicine, and he practiced full-time in South Florida through the middle of 2019. And through that, those years of clinical practice, spent about 10 years doing hands-on clinical research in a variety of clinical trials. Even after leaving his clinical practice mid-2019, he stepped up and joined the front lines in South Florida there to help manage the hospitalization surges that they experienced with COVID throughout 2020 and 2021. But most importantly, today, he's here to share his perspectives on successfully integrating oxygen therapy to improve your overall quality of life. So with that, I will turn it over to Dr. Robinson.
Thank you. I'm going to take my video off and let me make sure you can see my screen. I'm happy to meet you all. I think we're at 102 that I can see, and I'm hopeful to, let's see. Can you see? I won't waste everybody's energies.
That's quite all right.
Forget the technological concerns. I am happy to be with everyone today. I think, you know, one of the pitfalls of being a pulmonologist is that you oftentimes have to liaise with clinicians who are unfamiliar with the prescription of oxygen. And I think the idea that it really should be straightforward, but we've made it the most difficult thing to do is why I'm happy to share my insights, or at least my perspective. I'll just go to the next slide. I think ultimately, there are three things you should hopefully get from your clinicians when you're prescribed oxygen therapy. One is good education, and I understand that education is woeful. We need to do better. My prior residents, I would spend a good amount of an hour just to ensure that they understood that oxygen wasn't just air, that oxygen is actual drug. It has an intended consequence, meaning that there's a dose, there's a response, there's a route of providing that oxygen that needs to be considered. But then, you know, I think most oftentimes we forget that there's a frequency as well. Typically, the clinicians I've worked with would prescribe oxygen in many settings, hopeful for a full 24-hour day, understanding that, of course, for most patients, they may not require oxygen 24 hours of a day, 7 days a week. And so it really requires a clinician to understand not just the condition that's being treated, whether it's COPD or pulmonary fibrosis or pulmonary hypertension, but specifically the patient. You know, I think we forget when we write these prescriptions, there's someone attached to that lanyard, that long cord with a nasal prong. And we really should remind ourselves every time we write a prescription that it's an individual process. So just as you would hopefully have your doctors individualize your diabetic medications or even your inhaled therapies for COPD, you really want your clinicians to think about individualizing your oxygen therapy and care. And more importantly, what we find is many clinicians have kind of a rote memorized fashion with which they write their oxygen prescriptions. And I'll give some examples for that in a second. But I think the homework that I asked my patients to do when I was in private practice was to hold me accountable for what I'm prescribing. So tell me whether the settings that I've prescribed are appropriate, meaning they're keeping your oxygen saturations over 90% at all times. And then conditional needs. You know, I worked in pulmonary rehabilitation, and so my job and my goal was to ensure that my folks got back to an active lifestyle, which meant that I had to think about how I was getting patients out of the office home, if they were in the hospital, out of the hospital home. But more importantly, when you're needing to go to the grocery store, needing to take care of yourself at home or out in the yard or playing with your grandchildren, that those conditions were being met. And more importantly, that your oxygen prescription was such that you understood how to titrate yourself to keep you above that goal of 90% at all times. And so titration really does matter. I think what we've learned at the COPD Foundation and more importantly in pulmonary rehabilitation, and I'm certain Joe has spoken to you all about it at Right2Breathe, is that we really want to empower our patients to self-manage their condition and concern, which means that we really have to demystify the setting, and more importantly, demystify how much oxygen you should be able to maneuver on your own without a change in prescription that requires either a new device, new settings, and more importantly, if you've got a portable oxygen concentrator, that you understand that a setting on a concentrator is not the same as a liter flow that you would get if you were, say, in a tanked delivery system. And so those are things, again, even as clinicians, I've had to re-educate simply because they're not the same, and not being familiar with it means that there's likely to be some misprescriptions out there that need to be adjusted. So the reason we prescribe oxygen is simple. We know that in patients who unfortunately have damage to their lungs, they're going to require in some settings to increase the amount of concentration of oxygen that you would breathe in order to keep your blood levels appropriate. So working mind, working heart, working kidneys, working vital organs are important, not just to quality of life, but obviously keeping you walking on this planet of ours. And so I think once you've gotten, unfortunately, to a level where your oxygen levels fall, and for many patients, that's 88% or less with doing whichever activity, whether that's at rest, during sleep, or watching The Price is Right, then you're going to want to make sure that you give yourself that necessary amount of oxygen to keep yourself above that goal of 90%. And so I've given some examples here of the different types of oxygen supplementation and conditions where we would prescribe. There are probably 3 more that I could think of, but I think overall this gives kind of a good description of what you should expect if you're prescribed oxygen. And long-term oxygen therapy, or LOT, is generally anytime you use oxygen for 15 hours or more. I think ambulatory oxygen is the area where in pulmonary rehabilitation, it really gives us the opportunity to really see how folks improve. I think oxygen utilization improves in patients during rehabilitation because, again, once you have working muscles, sometimes those working muscles no longer require as much oxygen as they did prior. And so we've had opportunity to see folks who required ambulatory oxygen therapy who no longer required it once they were up and active. Again, that's not every patient that we saw, but certainly now if you can become more efficient in your activities, then your heart's going to kick in and it's going to do what it's supposed to. I think most of my patients were always surprised to find out that 2/3 of our oxygenation requires good red blood cells, so good red blood cells to carry that oxygen. And then the other third would be a good, strong heart to deliver all that oxygen to your vital organ systems. The lung is really only 1/3 of that process. So if you're not anemic and you've got a good, strong heart, again, accounting for how severe your lung function may be or lung function loss may be, it's possible for some patients to actually come off of an ambulatory oxygen therapy. Nocturnal, I've used to caution all my patients that if you're prescribed oxygen at night, I know sometimes it can be difficult. The concentrators that you all have are likely in a closet someplace because they're bulky and loud. But if you're prescribed oxygen at night, that's an important part of the day for any patient that is hypoxic or with low oxygen saturations. And I used to tell my patients that the most dangerous part of the day, any part of the day for a patient that requires oxygen, is nighttime. And so if the most dangerous part of the day for you is when you're sleeping and you can't wake yourself to a point to get yourself back up to a safe level of oxygen, I would encourage any patient that's had prescription for nocturnal oxygen to get about it as close as you can to 100% use, because again, I can't protect at night while folks are sleeping, but we can give you some ways to minimize any of those risks while you're sleeping. And that's what nocturnal oxygen therapy provides for folks. Now, short burst is it's brief and intermittent oxygen supplementation. So there are some patients, very few, who unfortunately become extremely short of breath. The caveat is that, forgive me, I'm a God-fearing man. So God was, I think, helpful in making sure that we never really perceived when our oxygen levels were too low and forced us to have to breathe rapidly or deeply enough to keep our oxygen levels safe. That was on purpose physiologically. But there are those situations where some patients actually do, unfortunately, get to a level of oxygen saturation where, again, their minds tell them that they need to work hard to breathe. So that's that short burst or an intermittent oxygen that we would prescribe for patients, just to, again, relieve the anxiety and the anxiousness that can go along with having an acute episode where your oxygen levels fall too low. That's a specialized condition, highly specialized diagnosis. I won't go through the diagnosis, but I'm certain if you've had opportunity where you were worried about whether your oxygen levels were causing you to feel short of breath, please use your pulse oximeter and determination. If you're over 90%, then not likely to have had the condition that warrants you to require a brief or intermittent oxygen. But that being said, for all my patients, if they've had a prescription of oxygen, it's not going to hurt you to treat yourself. But again, I think the concern I always have is that if you're looking for 100% improvement, if you don't have one of the conditions that I'm describing, I think 50% is better than nothing. But I wouldn't expect 100% in those short bursts if you don't have the unfortunate dyspnea, the shortness of breath that's related to truly having low oxygen saturations. So let's go with the scripts. And I think this unfortunately, is an example of what oftentimes I would see in pulmonary rehabilitation. Pulmonary rehab for me was a great way to not just work with folks to get them back to an active lifestyle, but it allowed for me to help titrate their concerns from other clinicians, other pulmonologists, other internal medicine or family medicine physicians. And oftentimes that meant that I was helping to tinker with their oxygen. And so whenever I saw the original scripts that were similar to this, where they knew that they wanted you to have oxygen at home, that they knew the liter flow that would likely be necessary to keep your saturations appropriate. But in the script, there's very little description for the durable medical equipment company to actually go on. So oftentimes it requires multiple calls back to your physician, probably multiple scripts where the answers were not being generated or created. And this sort of phenomenon is why we now have that certification process where we have to fill out a form that comes directly from CMS or Medicare in hopes of us being more descriptive of what it is we're trying to accomplish, the supplemental conditions that we were discussing above, but more importantly, helping the DME company to specifically prescribe the oxygen that's intended to keep you safe. So the things that I want you all to remember is in your script, you want to make sure you've accounted for the dose. So make sure you know the flow of oxygen that's necessary or the setting that's necessary to meet that condition. The route, some folks unfortunately require something more than just a basic nasal cannula to keep their oxygen saturations appropriate. Some folks do require a face mask, which does require a higher flow. Some patients use a special type of cannula. We used to call them a mustache. It looks like a mustache. It's an oxidizer mask, if you're familiar, if you've had to use one. Helps to concentrate the oxygen outside of the cannula so that every bolus of air that you're inhaling has a higher concentration. But I think the route also entails making sure you know that if you're getting a tank, that you have enough, or at least enough of them to make it through a day if you're going to be ambulatory. Those will mostly be B tanks for some if they need something small. E tanks would be the larger tank that many patients are familiar with that goes into a little cart that you have to wheel behind you. And obviously, I really think we should be 21st century physicians. And so there's no reason we shouldn't try at every level to get folks something that generates oxygen like a concentrator so that, again, becomes more efficient. And again, the portable oxygen concentrators that are on the market now are getting very light, easy to carry, go into nice backpacks, easy to get in and out of the car with so that you're not trying to get it out of it. I hated to see folks try and take their tanks out of the back of their trunk. Especially if they had some mobility issues. And so I like that we're thinking very much about active mobility and improving quality of life in oxygen needing patients. And then timing. You want to make sure that you've had the prescription very specific to when you require it. As I've stated, some folks can watch TV all day long, which I don't prefer, but I know some folks, when they get tired, that's their activity. They may not require oxygen therapy during those periods where they're resting or watching television, but certainly they need to know if they're up and exerting themselves that they have to pre-oxygenate themselves, put their cannulas on before they hop up off the couch or out of bed and do anything that's going to be exertional. And then certainly, as we were discussing, if you've got nighttime use, you want to make sure that, again, you've got prescription that's specific to your needs at night. So again, the timing is everything about how you're going to get your oxygen prescriptions. So this is my example to give kind of a better idea of what we really should, if again, not using the CMS, at least the certification form. This is a better description of what your prescription should look like. Tells you the liter flow, so the dose, tells you what type of device or your e-tank, tells you when. I underlined at rest here. I gave you your goals. So your homework assignment is to maintain an oxygen saturation greater than 90%. Now I've highlighted with a red arrow because this becomes a point of contention between not just insurers, but also DME companies and clinicians. This is the one area that I think is most specific to the needs that patients probably are unaware of, that they probably should know up front, which is there are different ways of giving you that oxygen. It can come pulsed, which means every time you take a breath, it'll pulse the bolus of air that you require to keep your oxygen saturations appropriate at the liter flow. Or you can get a constant flow, which is a regulator change that just gives a continuous flow of oxygen. I like pulse regulators. It helps, especially in a tank, to conserve the amount of oxygen and air that's in that device so that you don't run through it too quickly. But again, in some patients, their saturations get to a level where they do require continuous flow just to maintain. Yes.
I hate to interrupt, but I can't see your whole page here.
That's
I see you and me and someone else on here, but our pictures are covering half. What do I gotta do to fix that?
Oh, so you're not able to see any of the slide that I've got up currently?
I can see the hometown clinic one to the arrow. I can't see what's to the right of that.
Those are just numbers, license numbers. They're all fake numbers and
Okay.
nothing of interest.
Okay, maybe that's all everybody's seeing is what I am. I don't know.
Yeah, it may be a little blurred because I don't have it in presentation mode. I've got it up on the screen here.
Okay. Thank you.
But it's this area here under the RX that I was most concerning in regards to what you should be able to pick out on your prescriptions if you're taking an opportunity to look at what your doctors are prescribing. That second condition I have on this slide is for the exertional concerns. So this is where I think you really want to talk to your doctors about how you're doing at home when you get you these devices, because typically doctors will write for 4 liters, the 2-liter, 4-liter flow without any description. And I think the 6-minute walk that hopefully you're all doing when you're getting your prescriptions are important because some folks only need 3 liters. They don't require 4 liters to keep them safe. Some folks may actually need 5 liters, which is a lot of oxygen to be given through a nasal cannula. But again, I just have by an example here, 3 or 4 liters, again, based on your exertional needs, and again, based on testing. I really do wish that at some point we understand that respiratory therapists should be able to go to the home. I think respiratory therapists going to the home would really hone in and streamline the process of oxygen delivery, help with the education that the patients require, potentially fill in the gaps of education that DME companies can't on how to use your devices, how to use your pulse regulator, how to use your continuous regulator. But that's an issue I think from a COPD Foundation standpoint, we're going to continue to grapple with. And I know the AARC is also looking to hopefully get some ability for respiratory therapists to come to the home to help out our patients who require oxygen therapy. I do have another prescription example. This prescription example is based on a portable oxygen concentrator, or even some concentrators at home that are fixed devices where the settings don't correlate to a liter flow. So this is where, again, if you've been given a portable oxygen concentrator or a concentrator to use, I really ask my folks when they go home to tinker with the settings. All right, and the settings are really about how much in say a milliliter of oxygen flow you're going to receive with each breath you take in. And so that's the bolus that I've referred to. And obviously the settings that you have are going to be based on how rapidly you're breathing. And again, without going too detailed into the physiology, if you're rapidly breathing, sometimes you're not going to be able to get that full bolus of air that you require, which means we have to change your setting so that you're able to get a larger bolus of air for the amount of respiratory rate or how rapidly you're breathing. And that requires you to actually go home and try it out, kick the tires on the car, drive it around the block, go to Target, pick out some stuff, and see what your oxygen saturations do. And I think the wonderful thing about holidays is you get to ask family members for toys, and a pulse oximeter is a great toy to have. So if you haven't gone out and asked somebody to think about you kindly at the holiday, that'd be one of the things I would certainly make sure you have in your toolbox is a pulse oximeter. Because again, a setting on a POC is highly specific to how you're going to feel and how you're going to behave when you're out doing activities, especially your activities of daily living. That's what ADLs are. And then again, they're typically given in a pulse setting so that as you the machine perceives you take a breath in, it will give you the bolus of air that's required to keep your oxygen saturation above 90%. So again, you're never below that 90% threshold. So what the heck is a pulse oximeter? I think the idea that, pulse oximeters now, especially with COVID, have really come to the forefront, and not just in management of chronic conditions, but certainly in acute conditions, means that we really should have spent some time, especially early in COVID, reminding folks what it is we're trying to accomplish with these devices, which isn't to use it as a way to scare us into telling us when we got to go to the hospital necessarily, but to tell us how we're performing with every beat of our heart. So that again, if you are having concerns and you're watching your pulse oximetry, you have the way to determine whether, again, you're being safe. If you've got oxygen prescribed, whether you can keep yourself above a certain level that might potentially be a part of your rescue plan. If you've got a COPD Foundation or a pulmonary rehab rescue plan that you follow in regards to how you decide you're in a yellow day or a green day, or more importantly, a red condition. But I think for us, it really allows for you to again, gather the data and the information that your clinicians need so that when you're going back to their offices, you can tell them how you're doing. You can tell them whether they're getting an A+ on their prescription or whether they're getting a big fat F and they need to go back to the drawing board about how they're prescribing your oxygen. So this becomes your way to keep everybody honest and more importantly, keep yourself safe and maybe a little bit of self-education about the things that you're doing at home so that you know how to set your settings on your devices so that you can stay active. So a pulse oximeter, again, 90% your goal. Anything above 90% is going to continue to walk on this planet with some safety. I think everybody tries to get to 100, but I always tell my patients when I had the opportunity that, well, I want you to be 100%, get an A+. You don't need an A+, you can be an A- and still pass the class. And so, I think the idea that everybody wants to get above 96% and demonstrate they can stay there, the goal is safety. And I think the idea is that in attempting to titrate your oxygen levels too high, some folks unfortunately cause their lungs to overwork. And unfortunately, that can cause some of that carbon dioxide, that bad gas that forms in our lungs to get back into the blood, cause folks to become sleepy and it can be a concern. So that's why I always remind that oxygen is a drug and that even though there's some benefit, there's also some negative consequences. So that's why your pulse oximeter becomes a great tool to help you understand where you're at, where your conditions are that you can do your activities and that keep you above that threshold of 90%. And again, you don't have to shoot to be 100%. And I think the goal is that if you can stay in the middle 90s, that's great. But certainly you don't want to try and make yourself too good because again, you might inadvertently hurt yourself by causing too much oxygen to cause carbon dioxide to leak back into your bloodstream and make some folks a little sleepy. And we've seen bad outcomes when folks overprescribe or dial up their oxygen too high. So that's why the pulse oximeter becomes great. So there are two things we're measuring: your heart rate, which is your pulse, and then your saturation, which we've discussed. So they're both continuous and they're not always going to be the same. So that's why I always tell my folks to really look at your conditions, put on that pulse oximeter while you're walking around slowly, put it on while you're, say, walking quickly if you're chasing grandkids, so that you're able to, again, see what your saturations are doing, because they're going to be all over the map. They shouldn't be the same at every breath and shouldn't be the same at every heart rate. But the two together really does give you the opportunity to see how safe you are. And more importantly, make sure that if your saturations are bouncing all over the place and you're doing multiple things in a day, that to keep yourself at a certain setting or a certain liter flow so that you never fall below that 90% threshold. And then, as I said, most folks, these devices are not perfect. So we do already recognize some variance of about 4% in a pulse oximeter. That's why I say you don't need to be 100%. If you're 96, you might already be 100%. And certainly if you're at 92, you could always be up at a 96%. And so build that in. And obviously the opposite of that's true, which is that if you're 90%, you're right, you could be down at 86%. But I certainly wouldn't look at those numbers and not have watched yourself for a good couple of minutes, especially if you're doing an activity, and more importantly, if you're at rest, so that you understand exactly where your saturations fall around this 4% variance that these devices have. Because again, they're not perfect, but understanding that you can be higher than you're measuring on a pulse oximeter means you also can be lower than you're measuring on your pulse oximeter as well. So you want to watch those numbers closely and determining whether there's an adjustment that needs to be made to your devices.
And actually, Keith, I'm going to jump in for 1 second. I see a couple of questions that are popping up, and we can wait on those or we can get to those now. And the other thing I wanted to just ask your opinion on, I've heard other people say it, exactly what you were talking about. When you're looking at that number of 90, but maybe you're not feeling quite right, does that mean that, in other words, look at the pulse oximeter, but also pay attention to how you're feeling? Is that appropriate, or would you recommend that, or what are your thoughts on that?
That's absolutely true. As I said, without having any knowledge of the lung function loss or at least the understanding of why oxygen was prescribed up front by your clinicians, again, there are some folks who are truly hypoxic to the point where when their levels fall down too low, it can stimulate the breathing centers of our minds and make us a little bit more anxious, which makes us breathe harder and increase our respiratory rate, which makes the condition worse. So kind of a rolling downhill phenomenon. So in that setting, I generally tell my patients, instead of dialing and cranking up the oxygen, a slow and as you go kind of mode is how I recommend it. So if you're on a liter flow, instead of going from 2 to 4, which might be a really high jump, if you're at 2 liters, go to 3, watch your pulse oximetry. If it's not making you feel better after, and give yourself some time. It's not going to be immediate, but certainly within a minute. If you're not noticing a change, then go, instead of 3 to 6, go 3 to 4. So 1 liter at a time. That'll make sure, again, that you're not dialing up the oxygen too rapidly, because again, overshoot can be a concern. But you also want to give yourself the time to recognize that maybe that 1 liter change was effective, so that again, you're able to better understand how you're going to use your liter flow in a tank, or your settings if you've got a concentrator, so that you're able to, again, keep yourself above what this question answers, which is, why do we titrate? The idea is, we know that in patients who learn the ability to titrate and our ability to help you get to the right safe oxygen, we were able to decrease mortality in folks, meaning we got more folks through the next holiday because they were doing the things that were necessary to keep their saturations appropriate. So I think the idea is that and learning how to titrate, and I wouldn't call it monkey or play with, but certainly understand how to use your device. It empowers, and it makes it a lot easier discussion when you come back to the offices to say that this is what happened when I did X, Y, and Z. This is what I expected. This was not what I expected. So that, again, you can have a more fruitful discussion about the device, because oftentimes you've been given the wrong device, and maybe it's not able to meet your needs. And the only way to really know that is to get back out and try these devices in all these conditions we're discussing, and learn to titrate them so that you can see if you're getting an appropriate level of oxygen. Because again, I may choose the wrong device. DME companies may not have in stock what I wanted. And so you're going to get, unfortunately, what your insurance companies will pay for also. I'm aware of that. Or more importantly, I'm also aware that there's co-pays for some of these devices, and so what you can afford. And so understanding that there are a lot of things that can mess up the plan of care that may have been enacted by doctors means that once you're given a device, it's not a one and done. Please understand that you can go back to the store, meaning the physician, and tell them you want something different. So don't think that just because you got one thing, you can't transition into something completely opposite and different. Because the whole goal, again, is to do what we see here, which is keep your saturations titrated well enough so that the mortality risk associated with not having good oxygen goes down.
So yeah, I mean, simplifying it for some of the folks, I know we have some folks on the call who are very new to having oxygen. I did get a private message, someone asking me, what does titrate mean? And so if you want to touch on that just briefly, but to really put it in layman's terms, for people who are hesitant to use their oxygen, right there, again, it looked like what we saw was use your oxygen, use the pulse ox to make sure you're getting enough, because there is real science that links that to actually living a better and longer life, right? I mean, that's a pretty simple way to put it.
Absolutely is. I've been saying it a lot, do your homework. I think the idea that once you're prescribed oxygen, the game's not over there. Obviously, you're going to have another couple innings to go before you can call it a done with the titration process. So titration is finding and dialing up and dialing down where your oxygen requirements will be, because I think the idea that real life information is a wealth of information that doctors never get in a 15-minute, 20-minute discussion with you, means that in your ability to learn how to turn up or turn down the amount of oxygen that's prescribed, and what conditions you were in when you elected to do so, really does allow for oxygen therapy to be owned by the patient and less by, say, the DME companies, and certainly less by the physician. Because I think the idea that we're providing you something that, again, not too different than a drug for, say, blood pressure or heart disease. We're prescribing something that's got an intended consequence. And so we want you to understand that, and more importantly, to feel comfortable to understand how to turn up the oxygen when you require it, and how to turn it down. I know there's some devices that are in development that will do that for you. That's 21st century medicine finally catching up to what patients have requested, which is, if I'm working hard to breathe, then keep up with me. Don't make me have to decide. Just like a car, in regards to stepping on the gas, it'll keep up as long as you've got enough oxygen. So I think these new tanks that are going to be coming out for folks will do that process and make it seamless, especially if you're using your pulse oximeter. So that
cruise control.
That's right. We're getting towards cruise control, and I'm happy that we're finally getting there.